Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Amber Williams. Today's episode features expert discussion of the latest frontline treatment options for advanced Hodgkin lymphoma and approaches to personalizing treatment for the general patient population, older patients, and pediatric patients. We're joined today by Dr. Jonathan Friedberg from the University of Rochester, Dr. Alex Herrera from the City of Hope Medical Center, and Dr. Kara Kelly from the Roswell Park Comprehensive Cancer Center. This episode is part of a larger educational program titled Transforming Frontline Therapy in Hodgkin Lymphoma, Advancing Personalized Strategies for Optimal Outcomes. For more information on our expert faculty, along with a link to the larger educational program and to claim credit, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say.
I do want to frame the landscape a little bit and emphasize some of the challenges of trying to make treatment decisions in Hodgkin lymphoma. And we have to think about that as we go through the evening, particularly with this focus on children and adolescent and young adult patients. The clinical trial data that we have generally as short-term follow-up. You get response rates, you get some progression-free survival signals, usually at 2 or 3 years. And long-term follow-up, in quotes, for a clinical trial might be 5-year follow-up. But we know in this disease, as a paradigm for other diseases in cancer, that there are late toxicities that occur. And for example, when aggressive radiation therapy used to be used for Hodgkin lymphoma, although initial responses were fantastic, the morbidity and at times mortality of these late toxicities was substantial, including breast cancers, cardiac disease. Some of these don't emerge until 20 or 30 years later, but if you're treating a patient who's 18 or 20 years old, that means they're still only 40 or 50 years of age. And when we're making decisions, we not only have to make decisions about what's going to be important today and what's going to cure them, but what's going to happen in the future. And the challenge is, of course, that the clinical trials don't have this, so we need cancer registries and special survivorship cohorts to study this, and this has been a real challenge. The 0816 trial and Rathel trial with ABVD led us to conclude that response adaptation was not going to substantially change the natural history of Hodgkin lymphoma. And fortunately, we had new agents that we could study. And the first new agent that came along was brentuximab vedotin that had a very high response rate in the relapse setting and as a single agent, even in patients who had relapsed after autologous stem cell transplant. When it was combined with bleomycin, it was overly toxic, but when taking bleomycin out and substituting with brentuximab, there were initial results that looked promising. That led to the Echelon trial that showed in long-term follow-up both a progression-free survival benefit and an overall survival benefit to the incorporation of brentuximab. And it was felt that it was going to be very hard to show an overall survival benefit in this scenario. And the fact that you saw it obviously created enthusiasm. And this became a new standard of care in many practice situations, particularly in the United States. This is not without toxicity, though. And the big toxicities that we see are an increased risk of febrile neutropenia. All patients on this regimen need to get growth factor. And neuropathy is a major toxicity with brentuximab. And over time, this neuropathy improves significantly and resolves. But a percentage of patients are left with neuropathy even 4 to 5 years later. And this neuropathy can be fairly disabling. And again, if you're dealing with young patients, this could mean major changes in their employment or what they would want to do. So that leads us to the other new class of drugs, and that's the checkpoint inhibitors, which obviously have very high activity in many of the solid tumors. The concept of these checkpoint inhibitors are they really take the brakes off of the T cells and allow the T cells to come in and cause anti-tumor immunity. Why is Hodgkin lymphoma so sensitive to PD-1 inhibition? And, a board's question that is often asked is, what is the number one tumor that responds to PD-1 blockade? And it's Hodgkin lymphoma. It's not melanoma. It's not lung cancer. And the reason for that was found somewhat serendipitously. This was not that we knew this and then decided to test PD-1 blockade, but it was in the reverse. The Reed-Sternberg cells, which have been hard to characterize because they're so infrequent in biopsies, have copy number alterations of 9p24 locus. This is where PD-1 and PD-L1 are encoded, and that results, based on a variety of these changes, in the highest single-agent response rates. Turns out that the mechanism of checkpoint blockade in Hodgkin lymphoma also probably involves innate effector cells, and this innate immunity changes similarly are such that by giving the checkpoint blockade upfront, it makes more sense. So taken together, this provides a strong rationale to incorporate checkpoint inhibition early in the treatment of Hodgkin lymphoma.
So in 2018, as it had been for decades, we used ABVD or BIACOP to treat newly diagnosed advanced stage disease. But we had gained this new option of brentuximab vedotin combined with AVD. And because of the toxicities that Dr. Friedberg mentioned with increased febrile neutropenia and increased sepsis, increased neuropathy, it was still a decision. Even though there, at least in 2018, there had been a progression-free survival benefit, there was still kind of decision-making to be had about which regimen to use. The overall survival benefit that came more recently in the last couple of years, I think, really kind of spelled the end of ABVD for advanced stage disease. But as Dr. Friedberg mentioned, there was a really strong rationale to start studying PD-1 blockade in the frontline setting, right? This disease, Hodgkin lymphoma, was uniquely vulnerable to PD-1 blockade, and studies incorporating PD-1 blockade into the frontline treatment of Hodgkin lymphoma, either combined with or sequentially kind of prior to AVD chemotherapy, demonstrated really promising tolerability and efficacy in the frontline setting. These studies using either nivolumab or pembrolizumab, either in combination with or sequentially with AVD chemotherapy, all have progression-free survival benefits greater than 90%, which is really, that's the best we had seen to date with kind of an ABVD backbone type of therapy. Based on this idea that there were still many patients who received brentuximab vedotin AVD who were relapsing, there was increased toxicity that was observed with, BV-AVD in terms of neuropathy and sepsis and febrile neutropenia, and this really strong rationale to use PD-1 blockade in the frontline setting, we designed the randomized phase 3 SWOG S1826 trial. Important to mention, this was a collaboration between the adult North American cooperative groups and the pediatric cooperative group, the Children's Oncology group. So we actually enrolled patients as young as 12 on the study, and there was no upper age limit because we weren't using BIACOP. So patients who could tolerate anthracycline-containing chemotherapy could receive either of these regimens. So patients with stage 3 or 4 Hodgkin lymphoma were randomized in a 1-to-1 fashion to receive either nivolumab combined with AVD or brentuximab combined with AVD. And patients on the brentuximab arm were required to receive G-CSF. Patients in the nivolumab arm it was optional to use G-CSF. And patients were stratified based on age, the IPS score, and the intent to use radiation at the end of therapy. And it was allowed for treating investigators to administer end-of-treatment radiation to residually FDG avid lesions. The primary endpoint of the study was progression-free survival, and we enrolled nearly 1,000 patients on the study. We enrolled about a quarter of the patients that were under the age of 18. About 10% of the patients were over the age of 60. A quarter of the patients were either Hispanic or Black. About two-thirds of the patients had a stage 4 disease. About a third of the patients had high IPS scores, and patients with HIV were allowed to enroll onto the study, actually. Overall, I think one thing to say about S1826 is that it was really a broadly representative study of the patients that we treat in North America, and also included high-risk patients, actually more than some of the other studies that had been conducted in the last decade or so in advanced stage Hodgkin lymphoma. The toxicities were as you would expect: gastrointestinal toxicities, hematologic toxicities, typical of a combination chemotherapy regimen. But one thing that we did see was more neutropenia with nivo-AVD. But that wasn't entirely surprising because it was required to get growth factor on the brentuximab arm. And what's important is that we didn't see any increase in infections or febrile neutropenia as a consequence of that increase in neutropenia. This is basically going back to the days of ABVD, where all patients really are neutropenic, and we're not it's not necessary to give growth factor. A lot more bone pain in the brentuximab arm because of that growth factor use. There was quite a bit more neuropathy in the brentuximab arm, and higher grade neuropathy, right? Almost 3 times the amount of, grade 2 or higher peripheral neuropathy. There was more thyroid dysfunction in the nivolumab arm. Any of you that are familiar with these, checkpoint inhibitors know that that's pretty common. There was more liver function test abnormalities in the brentuximab arm. There weren't really high rates of immune-related toxicities in the nivolumab arm, which was reassuring to see. There really were, pretty major tolerability differences in patients being able to continue, get a full course of therapy. So in the brentuximab arm, 12% of patients had to discontinue therapy completely, compared to less than 8% in the nivolumab arm, and 22% of patients discontinued brentuximab at any time, compared to 9% in the nivolumab. 27% of patients actually had dose reduction of brentuximab vedotin. And importantly, there were very few patients who received radiation, less than 1% of patients, which is quite a big paradigm shift. Most importantly, S1826 demonstrated that nivolumab AVD prolonged progression-free survival compared to brentuximab vedotin AVD in patients with stage 3 or 4 Hodgkin lymphoma. At 2 years of follow-up, the hazard ratio was 0.45, and the 2-year progression-free survival with nivo AVD was 92% compared to 83% in the brentuximab arm. In parallel, while we were conducting S1826 in North America, in Europe, HD21 was an ongoing study, a randomized, again, phase 3 study. This was a non-inferiority study looking at trying to improve on this BIACOP backbone and incorporate brentuximab into BIACOP while kind of removing some of the chemotherapies that were causing a lot of the toxicity that we associate with BIACOP. It was a PET-adapted study. Patients who were PET negative got 4 total cycles of therapy, and patients who were PET positive and on their interim scan had 6 total cycles of therapy. The changes from BIACOP to BRICAD were omission of bleomycin, some minor changes in the doses of etoposide and doxorubicin, vincristine was omitted, brentuximab vedotin was added, and then most importantly, I think, in my mind, is that we removed procarbazine, which is associated with gonadal toxicity and second cancers, and substituted into carbazine. There was also some changes in the steroids, actually less steroids. Steroids were given for a shorter duration of time. But BRICAD was much better tolerated than BIACOP. And importantly, there appeared to be less impact on gonadal function. This is just measurements of FSH levels in men and women a year after therapy, and the FSH levels returned back to baseline in the BRICAD patients, this kind of brentuximab-based BIACOP regimen, whereas they remained elevated in patients who received BIACOP. So not only was BRICAD non-inferior, in fact, it was actually superior to BIACOP. At 4 years, the 4-year progression-free survival was 94% with BRICAD compared to around 91% with escalated BIACOP. Now, just to place the studies, the regimens a little bit into context, these are, there are some differences in hematologic toxicity and infections between BRICAD and what we observed with nivolumab AVD on S1826. There's quite a bit more grade 3 hematologic toxicity. Almost a quarter of patients required a red blood cell transfusion, 17% of patients required platelet transfusion with BRICAD, and 28% of patients who received BRICAD had febrile neutropenia, typically requiring an admission to the hospital. And all of those rates were quite different with nivolumab AVD. So just important to note some pretty significant kind of supportive care differences between the regimens and toxicity differences. 14% of patients require radiation in the BRICAD study as opposed to less than 1% that we observed with nivo AVD in S1826. So just to summarize, these new kind of modifications of these historic backbones, ABVD and escalated BIACOP, really have moved the needle and advanced, kind of brought a new paradigm of kind of novel agent-based frontline therapy for advanced stage Hodgkin lymphoma. Nivolumab AVD improved progression-free survival compared to brentuximab AVD in advanced stage Hodgkin lymphoma. It was better tolerated than brentuximab vedotin AVD. There were a few immune-related adverse events observed, which was reassuring. Very few patients received consolidative radiotherapy, and that may reduce late effects in this typically younger population. Importantly, it's a key step towards harmonizing pediatric and adult therapy. BRICAD improved progression-free survival compared to BIACOP, similar to what we observed in S1826, and BRICAD was also better tolerated than escalated BIACOP, with less impact on gonadal function. So overall, these regimens, these newer regimens were both more effective and better tolerated. We'll start off with a real-world case. 30-year-old woman with newly diagnosed stage 4 Hodgkin lymphoma, has a high intermediate IPS score. She's a violinist, and she's concerned about preserving her fertility. Dr. Friedberg, what are your considerations when seeing this patient in your clinic?
I think this is a fairly typical patient. IPS score of 4 is a relatively high risk. Working as a violinist, I think, is a question that neuropathy may be a particularly devastating toxicity for this individual. With these new agents, the knowledge on long-term fertility is limited, and we should emphasize that. There are hints that fertility is going to be preserved. I think we're comfortable with the AVD backbone that those chemotherapy regimens do not in and of themselves cause major infertility. But in somebody who's concerned about preserving fertility, I would certainly send them to have a discussion about options prior to starting treatment. Clearly, I think nivolumab AVD is the option that with short follow-up has the most likely chance that she's going to be cured. But the fertility preservation, would be recommended in the sense that we don't really know with nivolumab AVD combination in long-term follow-up what the impact on fertility would be.
Thanks, Dr. Friedberg. Dr. Kelly, how does this, kind of modify the question a little bit? This is maybe an 18-year-old, and maybe the 18-year-old isn't a violinist, but,
aspiring violinist.
Aspiring violinist, a freshman in
Prodigy.
college. Yeah, that's right. How does the discussion change a little bit?
I think it would be quite similar, especially in the younger patients. An 18-year-old, fertility is going to be a major consideration. So Nivo AVD would be a preferred option. I think the one thing, and I'll touch on it a bit in my presentation, is that some of the pediatric regimens are more dose intensive and are given over a shorter period of time. So for an 18-year-old who may be starting college, that is still a trade-off because Nivo AVD does take 24 weeks to deliver. So, I think, again, discussing with the patients, understanding what their priorities are is critical for choosing which regimen.
Yeah, no, that's an excellent point. Differences in the duration of these regimens is, certainly worth keeping in mind. How do you both approach management of a newly diagnosed Hodgkin lymphoma patient who has autoimmune disease? And let's say they have active disease that requires, let's say, a TNF alpha inhibitor in the case of inflammatory bowel disease.
I think it's a challenging question. We should emphasize that these patients were not included on the 1826 clinical trial. They were excluded, given concerns over autoimmune, exacerbation with the checkpoint blockade. And clearly, we know from other scenarios that there's the risk of that. That risk may be higher in these Hodgkin lymphoma patients because they're younger. And I think the younger immune systems may be more likely to increase. My approach to this particular case would probably be choice E, which would be BV-AVD. I have a lot more experience giving BV-AVD. Obviously, we were doing that for years before the nivolumab data. And that's likely what I would choose over BRCAD. The BRCAD results are probably better. And I think that's also a very reasonable answer. And I think both of those would be preferred over ABV.
Absolutely. Yeah, that makes perfect sense. Anything to add, Dr. Kelly?
Yeah, I think BV-AVE-PC would be our pediatric regimen, which was studied in the younger population and was associated with a high event-free survival rate. So that would be a consideration for a patient like this.
You have probably the most experience of any of us with the checkpoint inhibitors. And what's your sense as far as the risk of autoimmune exacerbations?
Personally, I agree with both of you. I would tend to avoid using nivolumab in a patient with active inflammatory bowel disease, as in this case. I think a lot of the folks who we've polled probably have a lot of experience with these drugs too, treating solid tumors. And I think it's perhaps a different scenario than what we might be thinking about in a patient with a metastatic solid tumor, right? So here we have, BRCAD or BV-AVD are associated with cure rates of upwards of 85 to 95%. And so I think given how effective the regimens are, and certainly we know that there's a higher rate of immune-related adverse events in patients with autoimmune diseases, I would tend to want to use a non-checkpoint containing regimen just to make sure we're getting to the therapy, we're not complicating things, we don't have to interrupt and delay and things like that due to hepatotoxicity or gastrointestinal toxicity exacerbating her inflammatory bowel disease. So I agree with both of you. And I think pre-CAD versus BV-AVD, personally, I've used a lot of rituximab AVD in these types of patients with lupus and other autoimmune diseases. And actually, it's gone, often the autoimmune disease gets better for a little while after they've gotten chemotherapy.
I think it's going to be very important for us to continue to follow the patients on 1826 and understand the intermediate toxicities and long-term toxicities. I think we all participated in that trial. We led the trial. At this point, we're not aware of any major signals of problems, and that's not only coming from our trial, but other studies of the checkpoint inhibitors that Alex mentioned that had longer follow-up. But, given the youth of this patient population, I think it is going to be important for us to continue to pay attention.
Absolutely. Really, really critical. So we'll advance the clock of, a few decades now. And as you all probably know, there's a late peak of incidence of Hodgkin lymphoma in older patients, kind of in their late 60s, 70s, early 80s. And so Dr. Friedberg is going to talk about considerations for older patients with Hodgkin lymphoma.
I think for the fit patient who is older, you should appreciate that any BACOP regimen is really contraindicated. It's not been studied in patients over the age 60 because when it was too toxic. So you're thinking of an AVD type of backbone, and given the poor outcomes that we've seen in contemporary studies adding BV to AVD, I think nivo-AVD is very appealing. The real question is what to do with the unfit and the frail patients. Unfit patients may be able to get nivo-AVD. We need to study that. But certainly some of the unfit patients and frail patients, I think there are some either single or doublet options that need further exploration.
So how do you assess frailty and fitness? And are we doing kind of get up and go walking tests in clinic?
I come from an institution that has an expertise and interest in geriatric oncology. We haven't formally moved a lot of that into our lymphoma population. Most of their data is in solid tumors. There are a number of tools that have been published and explored that include patients with various types of lymphoma. The most robust one is in diffuse large B-cell lymphoma that was developed in Italy. And this tool is relatively straightforward. You can do it in clinic in 5 to 10 minutes and does, at least for diffuse large B-cell lymphoma, categorize patients into fit, unfit, and frail. And I do think that we need to be able to do that when we do trials in this patient population. And for example, understand, can an unfit patient get nivo-AVD? Where's the cutoff where we would say that the patient shouldn't get combination chemotherapy? And in that small remaining group, what is the best option? Maybe BV-nivo is too toxic as well. Maybe you have to do them in sequence. So I think this is an unmet need to study this. I will speak from the U.S. Cooperative Group standpoint that we've had interest in studying this. But right now, it's very difficult to design a trial because the number of patients that we think are going to be eligible for this trial is relatively low, given the positive outcomes of the nivo-AVD. And I think we want to get a little more experience with that before we think about a study that maybe uses an integral biomarker of some sort of fitness tool.
It's perfect. I agree. It's really important. We're trying to do this more and more in our clinics too, to try to do a little better than just the eye test. One thing that I don't typically do in these patients, unless there's a reason why I can't give them brentuximab, if I have an unfit older patient with Hodgkin lymphoma, I don't typically give them PD-1 alone as the first thing.
I'll add one last thing. Just have to get one more point. So one tool that is a very effective treatment for Hodgkin lymphoma is radiation therapy. And, the risk of late toxicities in many of these older patients is negligible. They're going to be too old for those risks to occur. So I think that although I rarely use radiation therapy in advanced stage Hodgkin lymphoma, a scenario where it may be part of treatment and I have a lower threshold to give it would be for the older unfit patient. And even sometimes achieving a PR with, shrinking a lymph node that is causing symptoms can buy you a lot of time relative to their age.
Absolutely. I always hear in my head what you and other folks have said, that radiation is probably one of the single most effective therapies we have for Hodgkin lymphoma, and not to forget that. Okay, so next we'll have Dr. Kelly, kind of give a talk focused on pediatric and AYA patients with Hodgkin lymphoma?
We're really at a crossroads in managing Hodgkin lymphoma in the pediatric age group. And, historically, we treated things quite differently. And that really evolved due to the earlier recognition of many of the late side effects that occur from radiation, as well as high cumulative doses of chemotherapy. And so because of that, our patients are younger, they have many decades of life ahead of them. We developed different regimens that tried to balance some of the risks associated with that. And as part of those regimens, we also used quite different risk stratification compared to what's used in the adult groups. And unfortunately, too, which limits comparability across regimens, is that even across the different pediatric Hodgkin lymphoma clinical trials, there was quite a lot of variability in what's considered to be advanced stage. In North America, fortunately, we've had a bit earlier access to some of the new agents. And the first agent that we evaluated is the brentuximab vedotin with the Children's Oncology Group trial, AHOD 1331. And that compared kind of the standard Children's Oncology Group regimen for patients with both intermediate and high-risk disease, which is the 6-drug ABVEPC, kind of an adaptation of ABVD, including some etoposide and cyclophosphamide. So the new regimen replaced the bleomycin with brentuximab and omitted one of the doses of vincristine. So in this study, again, the risk stratification is a little bit different than the advanced stage studies on the adult side. So this trial enrolled patients with stage 2B and bulk, 3B, and all stage 4, and it was ages 2 to 21 years of age. This study, the brentuximab arm, was very successful. We saw an almost 10% improvement in event-free survival, with the brentuximab arm being up to 92.1%. Radiation was still pretty considerable, but compared to previous trials that had been done by the Children's Oncology Group and by the Europeans, radiation was a little over 50%. And it was mostly due to the presence of the bulky mediastinal masses. The other important point about this regimen is that it still is intensive. Overall, it was manageable, but it still is quite toxic and really does represent an opportunity for us to try to improve upon this with less toxic therapies, as well as identify ways to further decrease the use of radiotherapy. So we were fortunate to come together with our adult colleagues, in the National Cancer Institute's National Comprehensive Network. And we worked together to design the S1826 trial and included patients 12 and up. So here I'm presenting the results of the adolescent cohort. So this is patients aged 12 to 17 years. There were 240 in that age group, so a pretty sizable number of patients. I think the important take-homes here is it was highly effective with Nivo-AVD, 2-year PFS of 95%, 12% improvement over BV-AVD. And really I think most exciting thing was how few patients received radiotherapy. Only 1 in the Nivo arm, 2 in the BV-AVD arm received radiation, which is just an absolutely huge advancement for this pediatric Hodgkin management. Here I kind of summed up sort of what my thought process is when I'm seeing patients and trying to decide between the two regimens that are mostly used in North America. So the advantages of the Nivo-AVD approach, include the ability to limit the use of radiotherapy, especially in a patient with a bulky mediastinal mass, where in the AHOD 1331 approach, radiation was used in all patients. So we don't really have any data about whether we can omit that. I also, for patients with stage 4B involvement, especially if there's bone marrow involvement, that group did not show a benefit with the 1331 approach. Some of the acute toxicity concerns, there's less peripheral neuropathy with Nivo-AVD. You can avoid use of bone pain from growth factor use. And there's a marked reduction in febrile neutropenia. From a long-term toxicity, we anticipate that there's probably less effect on fertility with the Nivo-AVD, since the AHOD 1331 regimen still includes 6 grams per meter squared of cyclophosphamide. From a ease of administration, the Nivo-AVD is given once every two weeks, and it's much easier to tolerate. patient where I might consider BV-AVE-PC are patients that have comorbidities that may impact treatment choice. We talked a lot about the autoimmune disease that applies to this younger population as well. There still is, unfortunately, because we only enrolled patients 12 and up, we don't have any data yet on Nivo-AVD in the much younger population. Roughly about a third of patients that present in a pediatric oncology practice are going to be under age 12. And so we don't have any data there. So it is a little harder to know whether the safety of that approach in these younger patients. I think there still are, of course, we don't have the long-term data of the checkpoint inhibitors. There are some efforts that are underway, including a new initiative by the Childhood Cancer Survivor Study to specifically enroll patients on that study who have received checkpoint inhibitors.
I just wanted to kind of look ahead a little bit to the future directions, and where we are kind of moving in Hodgkin lymphoma, talk about some of the new drugs that are being developed and maybe some of the new approaches. We've kind of poked around this idea a little bit of starting to think about how to personalize therapy more and, risk adapt patients. Historically we've used PET scans, but, we saw that really PET scans are an imperfect tool. And in fact, with checkpoint blockade, PET scans are particularly imperfect. Really, when we use PD-1 blockade in Hodgkin lymphoma and we are trying to assess disease with PET scans, there's a lot of kind of non-specific FDG uptake that we see. And so, what are some other tools or other ways that we could think about assessing response, potentially risk adapting patients? And so circulating tumor DNA, many of you may be familiar with, it's certainly starting to have some uptake in many, in a solid tumor setting. And we've started to use it more in lymphoma. Circulating tumor DNA is a highly sensitive and specific way of assessing for residual disease. And we have several different studies now showing that we can assess the mutation profile of patients with Hodgkin lymphoma and with excellent sensitivity and specificity now start to assess for residual disease. Now that we're using checkpoint blockade in the frontline setting, we're curing more patients. Unfortunately, we're not curing all of the patients. And so patients are still going to, potentially need salvage therapies down the road and other novel agents. So what are we doing about that? There are NK engaging therapies, innate immune cells and responses might be important, in Hodgkin lymphoma and in the microenvironment. NK engager therapies have been found to be promising so far. Dual checkpoint blockade, I think in melanoma, for example, there's a lot of, LAG-3 and combined LAG-3 and PD-1 inhibition that's approved actually and is used. We studied that in Hodgkin lymphoma and saw that patients who had been resistant to prior checkpoint blockade actually responded to anti-LAG-3 and anti-PD-1 blockade. And also we've shown that with epigenetic modifiers like HDAC inhibitors or hypomethylating agents combined with PD-1 blockade can actually help recapture responses to PD-1 blockade in patients who are progressing on therapy. So patients progress on PD-1 blockade, you add the epigenetic modifying agent that have various immunologic effects, kind of tickle the immune system, and we've seen responses in those patients even after they progressed on PD-1 blockade. Here at ASCO, we've seen the presentation of two studies as oral presentations. One was combining chemotherapy and kind of typical salvage chemotherapy with ICE, and that was a randomized study comparing to just ICE chemotherapy alone, showing that the response rates and the progression-free survival was much better in patients who received PD-1 blockade combined with salvage chemotherapy. Not surprising, really. This is, has become a standard already, but this was nice to see a randomized study to validate that. And then a multi-center study showing that these NK engaging therapies combined with the infusion of NK cells indeed could produce responses in a multi-center setting.
I just want to do a quick plug for a study that we do have open now. This is for early stage Hodgkin lymphoma and kind of building on the successful collaboration with the adult cooperative groups. This early stage study is being led by the Children's Oncology Group, but was jointly developed together. This study is enrolling patients ages 5 to 60 years of age, and it's evaluating whether more of an immune therapy approach for consolidation therapy as a means of being able to limit exposure to conventional chemotherapy agents and radiation therapy. So the standard of care is using a EORTC H10 type of approach, whereas the experimental arm, after 2 cycles of ABBD, the investigational arm is 4 cycles of BV-Nivo, And radiation is only reserved for the slow responding patients, which we anticipate will be about 15%. So study right now is open at over 300 centers in North America, and just would encourage you to participate if you're part of the NCTN.
Thank you, Dr. Friedberg, Dr. Herrera, and Dr. Kelly, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Transforming Frontline Therapy in Hodgkin Lymphoma, Advancing Personalized Strategies for Optimal Outcomes, and to claim credit, please click the link in the show notes. And be sure to check back regularly for more episodes on important CCO oncology topics.